for today is myths and facts about PCOS. As ma'am has already said, that PCOS is an enigma. The more we read about it, the more we get confused, and there are so many new challenges we face every time. So, just to begin, that PCOS is the most common endocrinopathy of the reproductive age women. The prevalence is 8 to 20%, and it is the commonest cause of an ovulatory infertility. The genesis of PCOS is complex and it can present in a variety of ways. Hence, there is a diagnosis, the present out of three. One is either amenorrhea or oligomenorrhea. That means that she doesn't get the periods or she gets scanty periods at delayed intervals. Then there are signs of hyperandrogenism, which can present either in the form of acne, hirsutism, or there is a polycystic appearance of follicles of ovaries on the ultrasound. Either the volume is more than 10 cc or more than there are 10 to 12 follicles in each ovary. However, if the oligo or an ovulation and hyperandrogenism is present, then ultrasound is not necessary. So with this, I just go ahead and clear all the myths. The first myth is, have I done something wrong to cause PCOS? So many patients and even the mothers come with their daughters. They are worried that my daughter has PCOS, or even the young patients can come and they would say, doctor, what should I do? How can I prevent that? Of course, there are measures what we can follow and what we can do to have control of the PCOS and the manifestations and the long-term risk factors. But somehow genetic factors do contribute to as high as 70% of the causation of the PCOS. Especially if the woman has mothers, if the mother is positive, then there is a 20 to 30% chance of the girl having PCOS. And if the sibling is positive, then there is a 40 to 50% chance that the girl will have PCOS. And however, there is an interplay of neuroendocrine, hormonal, metabolic, genetic, and environmental factors. So the inheritance of PCOS is very, very complex. The process starts for the genesis of the PCOS starts in utero itself. There is a CNS programming, epigenetic changes, genetic variations. Then during adrenarche, there are changes, inflammatory factors, environmental exposures, further continuing in the adolescence, and in the adolescence then leads to all this complex presentation of the PCOS. Coming to the very important myth that ultrasound is must for adolescent diagnosis of PCOS. So many young girls come to us at the age of maybe like 15, 16 or 17, 18 even, that they get the ultrasound done, maybe specifically that their periods are irregular, or they get the ultrasound done for any other purpose. And once they get the ultrasound done, invariably in majority of the patients we all are dealing in our OPD scenarios, it would be written below a line mentioned that ultrasound is suggestive of polycystic ovaries. So it is a very, very important fact to know, and that less than 8 years since menarche, since the ovarian reserve is very, very good, we cannot label all the girls as PCOS, because invariably the ovarian reserve will be good. So to diagnose a adolescent girl as PCOS, these two factors are self-sufficient. One is oligoanovulation and one is the signs of hyperandrogenism. This hyperandrogenism can present as hirsutism, where there is an excessive hair growth, acne, virilization, alopecia. So that's how these young girls they present, and we can diagnose these girls as PCOS, and ultrasound is not recommended for diagnosis. This is by the international evidence-based guidelines by the Teddy et al. In 2018. So ultrasound is not, and these factors, these pictures which I have already shown, that there is acne, acanthosis, irregular periods, and hair loss. The next common myth is that AMH alone can be used as a marker for PCOS. But the fact is, AMH alone, it reflects the ovarian reserve and the number of growing follicles. We get to know How much is the ovarian reserve, how once she's being taken up for the treatment of either infertility, how will she respond. But it is too premature to say that AMH is a single test to diagnose PCOS is not validated right now. So AMH concentrations usually are elevated in obese and in non-obese girls with PCOS of comparable age and pubertal status. These are the international guidelines which says that serum AMH levels should not be used as an alternative for the detection of PCOM or as a single test for the diagnosis of PCOS. So the role of AMH is to plan our stimulation protocols, plan our dose of injection of gonadotrophins. However, as a surrogate marker alone to diagnose PCOS, we just can't rely on it. However, we do consider whenever the AMH is more than 3.3 or more than 3.6, it does give us an idea that the ovarian reserve would be good. Again, the PCOS that it affects only the overweight women. No, it affects both the obese and the thin lean patients. So obesity and PCOS, they are interlinked. Obesity can make PCOS symptoms worse. 38 to 88% of the PCOS, these are either overweight or obese. But uh, this thing PCOS is not entirely restricted to obese women. 30% of the women with PCOS, they are thin and lean. And for lean women with PCOS, the prevalence is even as high as 6 to 22%. But the thing is that thin lean patients, they can often go undiagnosed for years, especially if they have regular cycles. And so the current definition and recommendation by the International Evidence Based Guidelines, which says that 75 grams of OGTT is recommended to assess the glycemic index. Bmi more than 25, or in Asians more than 23, or if there is a history of impaired fasting glucose, impaired glucose tolerance, or gestational diabetes. So increased level of androgens, male hormones, acne, unwanted hair, and hair loss, they are more common in thin lean PCOS. The myth again, the common myth is that measuring serum insulin is must to diagnose the PCOS. But the fact is, the insulin resistance, hyperinsulinemia, does play a role in the body's increased androgen production and hence the obesity. Now, these are the signs which are suggestive that there could be insulin resistance in the patient, especially if the waist hip ratio is more than 0.85. In Indian scenarios, in Asian population, we do take a waist hip ratio as more than even zero point 0.8, suggestive of insulin resistance. Acanthosis nigricans, hyperandrogenism, all these are the signs which suggest insulin resistance. These acanthosis nigricans is just the brown velvety spots at the back of the neck. And so the current definition and recommendation and guidelines do not include measuring insulin level testing. Like very often, the patient comes to us, we see that the patient is obese and the patient does have all these signs. We do tend to measure the serum insulin fasting and the serum insulin PP levels along with the blood sugar levels fasting and PP. So, but the guidelines say that it is serum insulin is not a must to diagnose the PCOS patient. So these are the recommendations by the International Evidence-Based Guidelines, which says that 75 grams of OGTT is recommended to assess the glycemic index, BMI more than 25, or in Asians more than 23, or if there is a history of impaired fasting glucose, impaired glucose tolerance, or gestational diabetes, or there is a family history of diabetes type 2 or hypertension on high risk ethnicity. Then in that case, patients, we should be measuring either doing OGTT in all these conditions, and then all these patients above conditions, they should be offered uh, to get the OGTT done, so that once a patient is planning to conceive, we are already prepared. We can guide her that her blood sugar levels should be controlled before she starts her pregnancy. So again, it's a myth that if your menstrual cycles is irregular, you have PCOS. Now, below mentioned are the 10 most causes of the irregular periods, which are like hormonal imbalance, obesity, eating disorders, over-exercising, thyroid disorders, breastfeeding, polycystic, elderly, and stress. So irregular cycles alone cannot be taken as the sign of PCOS. The normal cycle length is 21 to 35 days. Other causes I have already enumerated, and pelvic inflammatory, uterine fibroids or polyps, and all these conditions, they also can lead to the irregularity in the menstrual cycles. Because when a patient or a female walks to our center and she says she has irregular cycles or delayed cycles, the first hint that it clinches your mind is that she could be having PCOS. But when you do the scan and when you see, she could be having very very poor ovarian reserve. She could have attained menopause, or she has premature ovarian insufficiency (POI). So all these are the causes for the irregular and delayed cycles and absent periods. Now, all acne are because of PCOS. We all get so many referrals from our dermatologist friends that the patient is having acne. She reports to the dermatologist, and then the dermatologist refer to us. But there are these are like the cutaneous manifestations of PCO: acne, hirsutism, alopecia, acanthosis, and seborrhea. So acne alone is present in 20 to 40% of the patients of PCOS. Hirsutism is present in 50 to 80%. However, there is a thin line of distinction between the acne in the PCOS and the non-PCOS. So in acne PCOS, there is a hyperandrogenism, menstrual irregularity, and insulin resistance. They don't respond to the conventional therapy. And once we do the blood test, we'll find the increased DHEAS level, increased androstenedione, testosterone, and insulin growth factor. And the PCOS acne, it tend to occur along the jawline. As I've clearly taken this picture clearly shows that the acne are present along the jawline, the chin, and the upper neck. Whereas the acne vulgaris, it most commonly occurs in 80% of the adolescents. Majority of them, they remit before the third decade of life. The androgen levels, that's how we distinguish that whether the acne, they are there because of the PCOS or they are there because of the acne vulgaris. Then the androgen levels would be high in PCOS, whereas they would be normal in the normal patients. And they can occur on any part of the face. Here we can see that they are present on the entire nose, chin, the entire area. So that's how we distinguish. But a word of caution is that there is a very thin line to distinguish. Just based on these two pictures, we cannot diagnose whether this is the acne because of the PCOS or this is the acne because of the non-PCOS. Now coming to alopecia also, the PCOS alopecia, there is a thinning at the vertex. We see that the hair are thin at the vertex. So there is thin at the vertex with maintenance of the frontal line, and there is a bitemporal recession. But the non-PCOS alopecia, the loss of hair in the central region of the scalp as well. So this is generalized, whereas this is localized, limited to the vertex and the bitemporal regions. So again, you can't get pregnant if you have PCOS, because many mothers also come before a girl is getting married that my girl was diagnosed as PCOS, she is pregnant or not. They are apprehensive for getting married, so they come to us. So PCOS, we know that it is the commonest cause of anovulation, and it represents 80% of the anovulatory infertility cases. But 30% of the anovulatory infertility cases. But 30% of the women, they still ovulate intermittently. The principal infertility treatment includes lifestyle changes. Ovulation induction is the common, we know, either using clomiphene, and all the international guidelines says letrozole as the first line of drug as an ovulation induction in PCOS patients. If the patient is being taken up for laparoscopy for any other reason, then ovarian drilling. But per se, to do ovarian drilling in a PCOS patient is not recommended. And if she doesn't conceive by all these methods, by lifestyle, by ovulation induction, or adding IUI plus minus, then IVF is the last resort as the third line option, which gives a good success result. Now, if you're not looking to get pregnant, you don't have to worry about PCOS. It's not correct, because PCOS spectrum, the metabolic spectrum, does include the cardiovascular diseases, hepatic steatosis, glucose intolerance, diabetes, hypertension, mellitus, dyslipidemia, hypertension later on in the life. These PCOS patients are at increased risk of all these metabolic syndrome later on in the life. And on the other, sleep apnea, depression, anxiety, eating disorders, and endometrial cancers, all these are we see at an increased prevalence in the PCOS patients. It can be cured by medicines and birth control pills. So we all hear in our OPDs, madam 3 साल पहले PCOS diagnosed हुआ था, अब ठीक हो गया है. So that is what we need to, and then they become lax. Maybe their periods become regular. Either they have done the lifestyle modification. So PCOS is like we can modify and prevent the long-term hazards. The healthy lifestyle interventions must be incorporated. We all need to tell them that the only management which it should start right at the time of early diagnosis is the healthy lifestyle. Daily physical exercises, eat less of sugars, and maintain a good no junk food. So lifestyle modifications is the cornerstone of managing the PCOS. And losing even 7% of the weight helps in regularizing the cycles. And coming to the modalities which we write, even if we give birth control pills, might we give it to regularize the cycles, especially in the patients who are married and looking for contraception also. Then probably treatment beyond 4 months, especially in adolescence, is usually not evaluated. But these as a contraceptive method, we can give it to the young married couples. And if the contraception is not needed and menstrual irregularity is the only complaint that patient she presents with, then we can give medroxyprogesterone for 5 days. The DIAN 35, the ESHRE guidelines do not recommend this because there is an increased risk of venous thromboembolism. Because as a dermatologist, as an acne, we know that the DIAN has got anti-estrogenic component, the cyproteron acetate. It does help in reducing the acne and the hirsutism, but the ESHRE guidelines do not recommend this as the first line, because with these drugs there is an increased risk of venous thromboembolism. So the ordinary drugs that we use, Novelon, Femilon, all these, they work wonderfully in controlling the PCOS. Metformin I'll not be covering because Dr. Shweta has a talk and she would be covering the entire talk on this. Just take home point from my talk is that metformin is not recommended in all PCOS patients. But if the BMI is more than 25, if there is a high metabolic risk group, if there is a impaired GTT, then, or if she's not responding to clomiphene cycles, if she's resistant, if she's obese, and BMI is more than 30, then probably we can consider all this. Metformin in all those conditions. Again, probiotics improve PCOS. Now, these probiotics, again, an enigma these days. The more we read about it, the more challenging it is becoming. Which probiotics, how much, what duration, uh, and it is based on the fact that the gut microbiome, that is the gut microbiome, which includes the bacteria, fungi, viruses, they influence the host defenses, and they modulate the metabolism and the insulin sensitivity. They also alter the sex steroid metabolism also. And it is seen that if there is a decreased diversity, that is, if there is a decreased diversity in the number and the types of species, then probably it does lead to, is a positive, one of the factor for the PCOS. But still, it is still, to comment this is still in the experiment stage. We need more data to confirm on this. And still no data is available for the adolescents also. So with this, I think I end up my talk. And